So, welcome to critical care and austere environments. We will discuss in more detail the treatment of the critical casualty. I have no financial interests in relation to this presentation. I don't own stock in any of the kit that we're going to talk about. I have no conflict of interest in relation to this presentation. In summary, what we're going to do, or overview, is we're going to talk about the different austere environments and what makes an ICU within those environments. We'll talk about some of the basics. We'll talk about critical care nursing checklist, body systems clinical assessment, HIT PFC. You probably have had PSC training in the past, but we're going to bring it into the austere critical care side of things. We'll talk about hemodynamic monitoring for remote medics, a bit of blood gas analysis, and of course, improvisation. On the bottom right, that might be your critical care unit. That might be your ICU. It could be a somewhat sheltered room. It might be a cot with a mattress and a stick for an IV pole. That might be your ICU. We're going to talk about what exactly makes an ICU in remote environments. So austere and operational environments, remote environments, limited resource, there's lots of different names that you can call this. It's found in the developing world. It's found in failing states. I won't name any. I don't want to offend anyone, but there are some states at the moment that are losing the ability to provide austere or provide critical care. Now they're in austere environments. Devastated nations due to natural disasters or political problems. Chronically poor, such as sub-Saharan Africa, where I'm focusing the majority of my doctoral research, and sometimes in military operations, is caused by security issues, public health emergencies, and unconventional situations. And we get stuck right in the middle of all three of those. So austere environments, it is a definition. It is not a location. If you look at any catastrophe at the moment, well, with the current pandemic, we're nearly getting into austere environments because there's not enough critical care ventilators to deal with the vast amounts of casualties that are happening from COVID-19. So we are almost working in austere environments. We very well might see that in the coming weeks and months. Natural disasters such as Katrina, where a huge hurricane hit southern part of America, and the paramedics working could actually see the hospital. It's just right there, but because of flooding, they can't get to it. They're working in austere environments. In austere environments, beds are a luxury, and we see this currently with ICU units and emergency departments with trolleys and gurneys in hallways, or now they're out in the car park. And there's, as we're recording this, we're seeing vast amounts of hospitals being built in car parks, and a convention center in Birmingham is actually building one. So you need beds. Beds are a luxury within an austere critical care unit, but you need them. There are different standards of nursing care in austere environments. So in best case, evidence-based medicine is the standard. And even in an austere environment, we advocate that you continue to provide evidence-based and best practice medicine, but it's not often the case. There's going to be different standards for training for nurses in austere environments and doctors and medical officers. Some countries will have a medical officer that you're working with who doesn't have the same level of understanding as a basic paramedic. And we have to be sensitive to their training and not step on people and cause international problems when you're working in some of these austere environments. Oxygen is a luxury in austere environments. Very often we don't have it, and we got to deal with it. A lot of the district hospitals do have it, and they have oxygen concentrators in-house, but they don't have oxygen piping. So the only way you're going to get oxygen into your critical care unit is with a D cylinder or a C cylinder, and they have to just rotate those out and go refill them. There's a lack of equipment, lack of drugs, and limited monitoring capability in austere environments, which means that you need to make up for that deficit. You need to have the critical care skills to be able to provide a critical care level evidence-based practice without equipment, without drugs, without monitoring capacity. You got to do the best you possibly can. Let's talk about what makes an ICU. So what magic wand gets waved to say this room is now magically a critical care unit? Well, you need a bed, obviously. Well, you need a protected location. You need a bed. You need climate control if you have it, and you need basic monitoring. So blood pressure, SpO2, temperature, glucose. These are all that even a basic EMT will have this capacity. And on top of that, you'll need hemodynamic monitoring, which we can do non-invasively. And we'll talk about that in this lesson, how to do critical care monitoring without invasive or severely invasive equipment that we won't see in an austere environment. Additionally, the ability to give blood products, which we can in an austere environment. You can do body transfusion, you can carry fresh flows in plasma, pack red blood cells, platelets. There's no reason why you shouldn't have the capacity to create a critical care bed anywhere on the planet if you have the ability to have these things with you and the skills to use them, the clinical ability, the experience working in the top-rated critical care units, so you know precisely what you need to be doing in these austere environments. This picture below is an ICU. This is Jason Jarvis, our tropical medicine lead, and a doctor working in Mesa, Thailand, I believe. And they have overhead protection from the rain, and they have an audience. So it's probably not the best for keeping infectious, if there's any possibility of infectious diseases being passed around. But they have a bench as a bed, and they have a whole bunch of ALS equipment out of a backpack, and they have 2 ALS providers. One happens to be a critical care doc, and Jason has had quite a bit of critical care training with our college. So there's an ICU. It's a 1-bed ICU, but there's an ICU. So if you have a bed, a medic, and blood products, and basic monitoring, everything we saw on the last slide, you have an ICU. If you have, if you add on to that SpO2, you have a good ICU. If you add hemodynamic monitoring, you have a great ICU. And add to the treatment of, add the ability to treat hypodynamic problems, and you have a Western standard ICU regardless of where you are. It's a matter of skill and knowledge training of the practitioner. It's the ability to provide this level training with limited equipment, but we'll talk about what needs to get in your backpack to provide an ICU. And the ability to create that in a hotel room somewhere, or as you saw under a tin roof in Mesa, Thailand. So therefore our challenge to you is provide Western level critical care under austere environments. That's our challenge, and that's a direction, a torch that our college is holding high. And we want to be able to train people and get them hands-on clinical experience with a critical casualty in an ICU environment, and know how to deal that with evidence-based medicine best practice equal to what they would get in an ICU in a Western hospital. That's our challenge to you. So be better, continue to improve so you can do that. There's no reason why you shouldn't be able to provide a basic ICU anywhere on the planet. How do you do that? Be great at the basics. We'll talk about this whole list, but let's talk about the first one, and there's a reason we put that there. Be good at the basics. Everyone wants to be sexy. Everyone wants to RSI, and they want to do the catastrophic hemorrhage, and they want to do all the really cool needle decompression, chest drain, and all this cool stuff. If you're not good at the basics, all of that cool guy stuff is not going to be good enough to save your casualty. Be good at the basics. Know how to BVM with one hand. Know how to look at a casualty and immediately know something just isn't right. And let's start getting some observations to find out what. In Special Forces, we have a saying. So what makes Special Forces special is not all the cool guy stuff, jumping out of an airplane and doing Zodiac and underwater demolitions and all that. No, what makes us good is we are very, very good at the basics. We know the basic immediate action drill for our weapon system. We know that how to PMCS or do a assessment on a assessment, how to assess a vehicle. So how to keep a vehicle up and running, how to set up a patrol base, how to set up just a basic sick call clinic in the middle of nowhere. Those are the basics. And if you continue to focus on the sexy stuff and you forget the basics, you're not going to succeed. So everyone wants to say, I've RSI'd this many people. Well, how many traction splints have you put on lately? How many pelvic fractures have you felt and stabilized? How many IVs have you put in? And everyone's like, oh, I want ultrasound. I'm going to use IVs for ultrasound. Brilliant. But how many IVs have you put in blindfolded or in a low light situation? Basics. My challenge to you is be good at the basics and then build on that. We're going to talk about a critical care nursing skills list for all the tasks that you should have under your belt. What basic tasks you should have that makes you a good critical care practitioner. We're going to talk about body systems clinical assessment and how to do a sick call type of clinic where it's not trauma or you're not using CABC. It's a medical issue. Again, we're going to hit prolonged field care. We pretty much implement that in everything. So we'll talk a bit about PFC and how that applies to austere critical care. We're going to talk about hemodynamic monitoring and what you can do with the basic kit that we mentioned a few slides ago. What you can do with a BP cuff, an SpO2, a glucometer, and be able to assess a few of the hemodynamic parameters, variables, with just this. Just what you have. You're born with some good medical equipment. Why not get some time and skills to make them a fantastic bit of medical equipment? We'll talk about blood gas analysis and acid base a bit, and we'll talk a little bit about improvisation. Don't forget the basics. Be a good clinical practitioner. So put a blanket under the casualty. Listen to the patient. Osler is absolutely correct. 95% of the diagnosis you're going to have in an austere critical care unit is listening to the casualty, and we don't do that well enough. Give the casualty some privacy, some basic humanitarian privileges of keep making sure that no one else can see what you're doing and see personal things going on. Everyone gets pain management. Everyone. No, I didn't say we take the pain away. Everyone gets pain management. One of the leading causes of PTSD in traumatic casualties is the fact that they don't get pain management. So be aggressive on pain management. We talked about the pain pack, the first rung of the pain management ladder. There's no country on this planet where you can't get paracetamol and ibuprofen. The pain pack, those two together. So everyone gets pain management. You don't want to ignore this. Everyone drinks water, and we do mean everyone. So if you have someone who has internal bleeding and possibly perforated bowel, Um, when I first started in the 80s and 90s, like, oh, you can't give them anything. They'll die a horrific death if you give them anything to drink. Oh my God, we can't operate on them because and okay, there's some science behind that. You don't want to give them a Big Mac, but drinking clear water is fine. Even if they have a perforated bowel, they can drink water. Now, and there's science behind this, but think about it this way. The average person drinks 1.5 liters of saliva in a day. So when we have somebody who we have a suspected GI compromise, we're not telling them to spit out everything that comes to their mouth. We're letting them swallow 1.5 liters of water. So everyone hydrates. In your critical care unit, everyone hydrates. Now, I put usually because you always need that zebra within the herd of horses that's going to indicate something different. But generally, everyone drinks. And the last one, be good at the basics. Document. Document. If it didn't get written down, it didn't happen. Here is the critical care skills lists. We got this in our field guide. Basically, we put a bunch of skills together that will make you a good critical care practitioner. Be good at patient observations and documenting them. Be good with respiratory problems, cardiovascular problems, GI problems, and we will send out this list as an attachment at the end of the lesson. But it goes on to renal, neurovascular, and basic physical care. We'll put a link to the list so you guys can have this. But go through this, and if you're not comfortable with anything on this list, fix it. You want to be a good, austere critical care practitioner. You need to be good at these. And most of these skills are basics. So if you don't do them on an ongoing basis, find some place to practice. Let's talk about body systems assessment. So in an austere critical care unit, actually in every critical care unit on the face of the planet, people have already been stabilized. So if it's a trauma or medical or something, they come in on the ambulance or they walk into the emergency room, we've already done the CABCs. We've stabilized them. Then we turf them off to the ICU, the critical care unit, or the med surg ward to go higher up the intensity ladder. So when they arrive in a medical surgical ward or an ICU in Western countries, we don't drop everything and quickly to catastrophic hemorrhage, airway, breathing, circulation, disability. If they turn south, we can fall back to that and be very successful with that. But if for a stabilized patient, we can, or if you're working in a remote clinic, if you're in someplace in an oil site in the middle of northern Africa, and they have you in a Connex box, and that's your clinic. Somebody walks in, if they're fine, they're talking to, you're not going to throw them on the ground and start doing CABC. So clinic-based assessment, this is page 24 of our field guide. There's a bunch of different systems and ways you can do this. SOAP notes, the Yanks love that for some reason. I always get confused. So we came up with the chart system. So we teach our guys to just write, and the reason this is good is you can do this with a blank piece of paper. So you don't need a patient care report form, because everywhere you work as a remote medic, they're going to have a different system. So we wanted to teach a system that can be drawn up from scratch. So you just get a white piece of paper. I use an A4 sheet and fold it in half to make it an A5 sheet. And I'll write down CHART down the side. And as I talk to the person, I'll get their chief complaint. What are they there for? I get HPI, so history of past illness. And this is where you don't quickly go over and blow by it. You spend some time. No, you don't want to hear, in 1957, they stubbed their toe, but you need pertinent history, and don't skimp on this. Sir William Osler was correct that 95% of your history, of your diagnosis, is from history. So this really is huge. and also with A, all personal, family, social history. And then you can start doing your review of systems, your head-to-toe exam, system by system, and do a thorough examination for any problems you might see. And then you can go to T, treatment, follow-up, and differential diagnosis. This is just a way for in a sick call system where it's not trauma. This seems to be a good way for us to remember to do a full clinic-based assessment. Be very good at providing care for long periods of time. In austere critical care, you're going to have this guy for a while until you can get him evac'd or sent to a local district hospital. Or if you're in a district hospital, send him to a regional hospital or the capital hospital. So you're gonna have him for a while, which means that you need to be good at PFC. You need to be excellent at the nursing skills found in N of Hitman, and we call it sheep vomit. The main ways to remember the different nursing skills that you need to be able to do. Let's talk about hemodynamic monitoring. So in an ICU ward, we have lots of very invasive equipment that's going to give us really precise hemodynamic variables. So we'll put a Swan's catheter in. It'll go all the way in to the aorta, or to the, you can put probes all the way into the heart and find exactly what your cardiac output is. You can your preload, your vast amounts of hemodynamic variables, and critical care docs and critical care nurses need this, and they use this to fine-tune their pharmacological options. We don't have that, and I'm never going to advocate putting in a Swan's catheter in an austere environment unless you do this all the time. So the college and a few of the faculty that are critical care qualified have put together some hemodynamic parameters that can be found, ascertained, and tested without a lot of invasive equipment. So on the left is our first and our primary, secondary vital signs. So CPRO is our primary vital signs, and we separate them out because you can get CPRO immediately by just putting a pulse ox in the finger and then doing central capillary refill. With critical casualties, we don't do peripheral capillary refills. He might be in a cold environment or something. We always do sternal capillary refill. You get their pulse rate, respiratory rate, and oximetry. And the CPRO is going to tell us immediately if we have a critical casualty or not. And if they're stable at CPRO, we can skip the secondary vital signs for now as we continue our chart assessment. But if they're starting to look like they're circling the drain, or there's some big red flags showing up, then we'll immediately go to the secondary vital signs, which is your blood pressure, ECG, your alert status. We use GCS, or alert and oriented ×4. We always want to get sugar levels and temperature. Those 5 secondary vital signs are vastly important. And I get a lot of contention with ECG. Oh, we're not going to have an ECG. No, absolutely not. I will argue until I'm blue in the face. There's no place on this planet that you will ever work without an ECG. They're $100 now. They're little 3-lead ECGs. And if you don't have it, you are not being a good practitioner. So get your secondary vital signs, and it's something you can carry. You can get your primary and secondary vital signs with a very small observational packet. A small bag or a case will have everything in there that you need for this. Also, you need urinary output, because we're good medics. We always want to get 50 mils per hour. Lactate levels. Now, there's where we can start having some discussions on whether or not you have a lactate monitor. It's going to definitely be in my truck kit. It'll definitely be in my house kit or clinic, and it may or may not be in my backpack. So the college, we have a few of these that are small enough that they could be in the backpack, but I don't have a problem if you're saying, I'm just not going to carry it unless I'm back in my SUV or my ambulance, and then I'll start getting lactate. Same with your CBC, chem panel. If you have your ISTAT or EPOC a point of care testing device. You're going to have that in your ambulance or your SUV, and you're going to have it back in your Connex, in your clinic, wherever you are. And I'm okay with that. Ultrasound, same way. Ultrasound really should be in your backpack, but if you don't get that until your truck or your house, then that's fine. And that's why we separated these out to 3. You have your C-Pro, which you should have on you at all times. Your Beast, your secondary vital signs, you can have in your backpack, and everything else you can have in your truck and house. What we're going to calculate is CVP, MAP, cardiac output, cardiac index, and systemic vascular resistance. These are all things that you can calculate without putting in an invasive monitor. So we'll go into that. Blood gas analysis. With the current point of care testing ability, there's no reason why you shouldn't have this in your truck and house. So the EPOC is on the left. It doesn't require refrigeration. The iStat is on the right. It requires refrigeration. And every 6 months, you have to plug it into a laptop and update it, which is a pain beyond belief. So you have a couple of options available to you. Innovations and improvisation. That book there, I have no financial investment in Dr. Iserson. I've actually never met him. He's a WMS guy, and I've never met him at any of the WMS conferences. But get this book. You want to be a good medic, get this book. It has a lot of really good information on how to improvise a critical care unit in resource-poor environments. On the left is vastly different type of improvisation, and we have a lecture called the Improvised Medicine that will cover some of that stuff. This is a summary, just a quick introduction.